the distinct pleasure today of having Shruti Gupta from Boston talk to us about something that we have been talking about for a while in Ottawa on onco-nephrology. Dr. Gupta is an assistant professor and a nephrologist at the Brigham and Women's Hospital and Harvard Medical School. She did her med school at University of Virginia and then residency and fellowship in Boston. She's got an MPH from the Harvard School of Public Health. And she's currently the director of the onco-nephrology program at the Dana-Farber Cancer Institute. She's got NIH funding. She's a co-PI of the Stop COVID Consortium. I'm sure you have seen a lot of papers come out from that. Most importantly, she's also the founder and president of the American Society of OncoNephrology. And we'll see how her career has gone into onconephrology today. Thank you, Shruti.
Thanks so much, Swapnil and Greg, for the invitation. So I'm excited to talk to you about my foray into onconephrology. And this talk is going to be a little bit different than some of the others that I've given, in that I'm not actually going to talk a lot about published work. I'm going to talk a little bit about stuff that's actually a work in progress. So these are my disclosures. And here are the things I'm going to cover this morning. So first, I'm going to talk about how my research career almost ended before it started. And this is a shout out to the other junior investigators out there who know that the struggle is real. I'm going to talk a little bit about my K23, which focuses on novel pathways and therapeutic targets for cisplatin-AKI. I'm going to touch on our multi-center study of glucarpidase for methotrexate-associated AKI, which is underway. And then I will finish by talking about the creation of the American Society of OncoNephrology, which is near and dear to my heart. Now, before I talk about my research, I thought it'd be a little bit fun to talk about my journey into nephrology and then more specifically onconephrology. And when I was home over the summer, my parents were moving and they were clearing out all of my old binders. And they were really annoyed because I basically kept everything from nursery through medical school. And they're like, "You're such a hoarder, you have to get rid of things." And I found this fun essay that I wrote for my AP biology class in 2004, where I talked about the formation of urine. And I like to think that maybe somewhere deep in my subconscious, that was the first time there was a seed planted for an interest in nephrology. Now, after I did my high school in Virginia, I went up to Yale for college, where I was actually a history major. And I really credit my time there as when I learned how to write, which is an important skill that I've carried with me. I then spent a year in Madrid, Spain, under the pretense of a Fulbright scholarship. But really, I spent the year sort of exploring Europe, and it was a fun way to spend a year before medical school. And I also learned another important skill, which is that I became fluent in Spanish. And then I came home for medical school to the University of Virginia. And it was when I was a fourth year med student that I actually rotated with Dr. Mark Akusa on the nephrology service. And I remember, him teaching me about the delta delta and hyponatremia. And I remember thinking, this man is like the smartest man in the world. I want to be just like him. And so that's really, I think, when my interest in nephrology was born. And I carried that up with me to Boston, where basically I've been cold ever since, but I probably shouldn't tell the audience here that. Now, before I ever did any onconephrology, as Greg knows, I worked with Gary Curhan, whom you probably all know is an amazing nephrologist, mentor, father, researcher, everything. And he and I actually did a lot of work looking at risk factors for hearing loss using the Nurses' Health Study and other cohorts. And that was really when I learned sort of the foundations of epidemiology. And I also learned, what it means to be a good mentor. I mean, Gary was incredibly patient and would meet with me for 1 to 2 hours each week. I didn't even know what a t-test or a chi-square test was as a second year fellow, but he really sort of saw something in me and, helped nurture that. And so I'm very grateful for that. Now, when I was a third year fellow, I started having my own continuity clinic and I started to attend a little bit on our inpatient service. And I noticed that we had this deluge of patients from Dana-Farber who had all of these interesting problems, and we had no idea how to manage them. And so I went to our chief, Joe Bonventry, and told him about this. And he said, I completely agree. This is a problem and we don't know much about it. And so I want you to be our director of onconephrology and figure it out. And he said, I expect you to become a leader in this field in the next few years. And I remember going home and shitting my pants and thinking, oh my God, like, how am I going to do this? I don't know anything about onconephrology. And so, I read textbooks like this one. I read papers by the greats, whom you may know, Keinar Javeri, Mitchell Rosner, Mark Perizella, Nelson Lung, basically tried to learn whatever I could from some of these sort of founding fathers of onconephrology. And I decided that I really did kind of want to build a research career off of this. And so, I put a lot of blood, sweat, and tears into a K23 submission. But lo and behold, it was triaged. It wasn't even discussed. And I remember being totally crushed. I thought it was such a sexy grant looking at biomarkers of checkpoint inhibitor associated AKI and biomarkers of stem cell transplant associated TMA, but clearly it wasn't received that way. And I remember thinking, this is really crushing, and am I going to be able to sort of pick myself up from this? And I said, you know what, I'm gonna still submit multiple more grants, and I did. I submitted 6 more grants, sort of at the end of 2019, early 2020, and all of them were rejected. And it was now the beginning of the pandemic, March of 2020. I was pregnant with my first child. I was just sort of feeling a little bit kind of lost. And I was thinking, I have to do some soul searching and figure out, like, am I really cut out for a career in academic medicine? But I said, I'm going to pick up the pieces as much as possible. I started working a little bit more with David Leaf, who sort of shared some of the similar interests in AKI and onconephrology. And we designed an entirely new grant focused entirely on cisplatin-associated AKI. Unfortunately, it was funded last year. And so, with that long-winded introduction, I'm going to now talk a little bit about some of the aims of my K23 and some of our preliminary data. This is sort of the overall structure of the grant. And the first aim focuses on an epidemiologic approach where we're going to be using target trial emulation to look at whether certain medications reduce the risk of cisplatin-associated AKI using this massive cohort that I've been building over the last 3 years. The second aim is really exciting. It's an interventional study and an RCT where we're actually giving high doses of MAG versus placebo to this very specialized population to see if it reduces the risk of AKI. I'm not going to talk about aim 3 during this talk, just in the interest of time and because this is sort of still in its nascent stages. But hopefully, if you like my talk, you'll invite me back in a couple of years and I'll talk to you about it then. Now, cisplatin, as you probably know, has been around for a long time, over 50 years, and it's still very much used in the treatment of a number of cancers, as you can see here. And despite efforts to find less toxic but equally effective alternatives to cisplatin, it's still very much used. And AKI is truly a dose-limiting toxicity and occurs in up to a third of patients after a single dose of cisplatin. And when it does occur, the AKI predominantly manifests as proximal tubular injury with ATN, but you can get other lesions as well. And this is a schematic I made that sort of highlights some of the potential mechanisms of cisplatin-associated AKI, where there's been a fair amount of research on this, and then some potential therapeutic targets. And I'm not going to talk about each and every single one of these, but I am going to focus specifically on magnesium because this is one of the central sort of tenets of my K, which is that hypomagnesemia potentiates AKI in these patients. And we know that urinary magnesium wasting is very common in patients who get cisplatin. It probably happens in 50% or more of patients. And there are these beautiful basic science experiments that were done by Dr. Solanki at Northwell Hofstra in 2014, where her group actually found that magnesium deficiency increases platinum accumulation in the proximal tubular cell by downregulating these key multi-drug resistant protein transporters that are responsible for secreting cisplatin into the proximal tubular lumen. And they then showed that administration of magnesium actually restores expression of these transporters and allows the cisplatin to be appropriately secreted into the urine. They also showed that cisplatin induces renal chemokine expression in the setting of magnesium deficiency, as you can see here, denoted by MAG-D, and that actually giving cisplatin supplementation, as denoted by MAG-S, downregulates this renal chemokine expression. They also showed that cisplatin treatment in magnesium deficiency is associated with renal cortical neutrophil infiltration, as well as increased renal myeloperoxidase expression. And renal myeloperoxidase, or MPO, is a heme protein and a catalyst of lipoprotein oxidation that contributes to tissue damage. So that's data from basic science studies. Now, what about clinical data? Now, is there an association potentially between hypomagnesemia and AKI in other settings? And the answer is probably yes. And we haven't published on this yet, but we actually have this very well curated cardiac surgery cohort of over 20,000 patients. And we actually found an almost linear association between magnesium levels and this composite outcome of severe AKI, renal replacement therapy, and death. And this association persisted even after we adjusted for a number of important variables like comorbidities, demographics, labs, and more. And so I think all of this sort of begs the question, can we actually show in studies that treatments like magnesium are associated with a lower risk of cisplatin associated AKI? And sometimes, particularly in the field of onconephrology, conducting RCTs can be very, very difficult. And I believe you already had a talk on target trial emulation, and so I'm not going to belabor this too much. But one of the biggest proponents and probably sort of the founding fathers of target trial emulation is Dr. Miguel Hernan, whom I actually had the pleasure of working with during our Stop COVID studies. But basically, what he says is that you actually can, if you emulate an RCT and you actually take into account confounders, things like immortal time bias, that you can actually emulate an RCT and have basically show whether there's a particular treatment that reduces the risk of a certain outcome. And he espouses these four key principles of target trial emulation, which is that you would use similar eligibility criteria as if you were conducting an RCT. You use the same time zero for both groups in order to avoid immortal time bias. And there's a sort of funny example where if ICU patients were given tea and crumpets on ICU day 3, and you subsequently did an analysis and found that those patients had lower mortality than the patients that did not get the tea and crumpets, well, that's due to the fact that the tea and crumpets recipients had to even live to day 3 in order to get the tea and crumpets. Thirdly, you want to make sure you adjust for all important baseline confounders. And then you analyze according to an intention to treat principle. And so, regardless of this potential for crossover later on, you analyze people according to the groups to which they were initially assigned. And like I mentioned, we did this in 2020 with our Stop COVID study. And this is not going to be a talk about Stop COVID, but I think this is sort of a good introduction into how target trial emulation can be used effectively. This was a time when we didn't have any data from RCTs to guide us on which treatments are actually effective in reducing mortality in critically ill patients with COVID-19. And so David and I actually, in a grassroots effort, single-handedly reached out to over 400 collaborators across the United States and ended up collecting very granular, detailed data on over 5,000 patients across 68 ICUs. And we were able to use this data to actually study 4 different interventions and see whether they reduced 28-day mortality in these critically ill patients with COVID-19. And as I mentioned, this was critically important because, this was a time when those who shall not be named were touting treatments like hydroxychloroquine and ivermectin, and we really did need data from RCTs. And so, we looked at tocilizumab, for instance, and found that there was reduced 28-day mortality among patients who had early receipt of tocilizumab in their ICU stay. And we similarly found mortality benefits for ECMO and early proning, and we found no benefit for therapeutic anticoagulation. And what was super neat about this was that our findings were later on corroborated by RCTs. But again, those RCTs took time. And so this just sort of shows that if you actually do analyses properly using observational data, you can actually get the right answer. And so, what does this have to do with cisplatin? Well, what I'm in the process of doing, and I actually just completed this big data set, is I've been compiling data of over 45,000 adult patients treated with IV cisplatin across 6 centers. So that's Mass General and Brigham, Dana-Farber, University of Colorado, Memorial Sloan Kettering, Northwell Hofstra, and MD Anderson. And the plan is to conduct 4 separate target trial emulation analyses where we'll look at 2 medications that are commonly given for prophylaxis against cisplatin AKI, which is magnesium and mannitol, and then 2 home medications, metformin and statins, to see if they reduce the risk of cisplatin AKI. And we've collected very detailed data on demographics, comorbidities, home medications, concomitant nephrotoxins, in order to make sure that we adequately adjust for confounders. And just to highlight the importance of selecting the appropriate patients for these studies, we would exclude patients with very low or very high serum magnesium levels for IV mag TTE because those patients would probably be excluded from a hypothetical RCT. And our primary outcome is going to be cisplatin-associated AKI, which we will define as an increase in serum creatinine from baseline or the need for RRT in the 21 days following that first infusion of cisplatin. And because this is going to be such a rich data set, we're going to use it to also generate a risk prediction model for cisplatin-associated AKI. And there was one actually done by Gary and colleagues here at Brigham and Dana-Farber in 2016, but that study was much smaller. It was only about 2,000 patients. And this study will be more generalizable. It's going to have 20 times the number of patients, and it'll be from across 6 centers. And so we're hoping to sort of recreate a better risk prediction model for cisplatin AKI. And we've already generated sort of a preliminary model, as you can see here, using some of the data we have thus far. And you can see a number of the risk factors here in the table. And I do want to point out again that we are finding so far that hypomagnesemia is a risk factor for cisplatin-associated AKI. And so, this segues to aim 2, which is actually putting this hypothesis about hypomagnesemia and cisplatin-associated AKI to the test in an interventional study. And as I mentioned earlier, we're doing this in a very, very specialized population of patients. It's very unique to the Brigham. These are malignant mesothelioma patients who undergo surgical debulking and then have this heated chemotherapy solution that's poured into their chest. And this solution is heated to 42 degrees Celsius. And this is an actual picture that you can see from the operating room with Dr. Bueno performing one of these surgeries with HIOC. Now, though this procedure is associated with a survival benefit, perhaps not surprisingly, these patients have high rates of AKI. And Sus Wykar and us, and I and David and others looked at all patients treated with HIOC at our institution, and we found that over half developed postoperative AKI, and 3% needed renal replacement therapy. And that's actually pretty remarkable because these patients at baseline all had normal GFR. So their baseline median GFR was 87. So the fact that 3% needed RRT is quite striking. Now, why are the rates of AKI so high? There are probably some synergistic effects of the cisplatin, some of which may be systemically absorbed, as well as surgical factors like blood loss and hypotension. We also know that the AKI in these patients is not benign because those patients, particularly with more severe AKI, not only had longer lengths of stay, but they also had higher long-term mortality. Now, I took that data set and I actually went back and I looked at the baseline magnesium levels of the patients who were going to undergo surgery with HIOC. And I found that those patients that had a magnesium level less than 1.8 had a 4.6-fold higher risk of developing stage 2 or 3 AKI compared to those patients with normal magnesium levels. Now, of course, this was an unadjusted analysis and the confidence interval is fairly wide. And that's because not all these patients had magnesium levels at baseline. But it's compelling nonetheless. And also, given the fact that these patients have such high rates of AKI, I showed you some very compelling preclinical data from animal models suggesting that there's biologic plausibility for actually giving magnesium. We wanted to test this in an interventional study. Now, you may ask, well, why this very sort of esoteric mesothelioma cohort? It's not like, every center across the United States does surgery with HIOC. The reason for it is because it's a very controlled and standardized setting. As you will soon see, we're giving very, very high doses of magnesium to these patients, and it's not practical to do this in outpatients coming in, receiving IV cisplatin, because right now they need to be very, very closely monitored. We're trying to figure out what is sort of the safe dose to give these patients. Also, whenever you're conducting an RCT, you want to make sure that you have an adequate event rate. And as you saw, these patients have very, very high rates of AKI, much higher than an outpatient coming in for a single dose of IV cisplatin. And the surgeon pictured here, Dr. Bueno, is a little rough around the edges, but he has really been a big proponent of research. He's doing many of his own studies, and it's always helpful when he goes in the room before we do, and he talks to the patient and says, I take magnesium every day, and there are a bunch of nephrologists that are going to come in and talk to you about it, and you should definitely sign up for the study. And so it's just helpful when there's someone who's sort of an advocate for it. Now, this is a picture of me actually going down to the OR and observing these cases and also working with anesthesia to figure out how to titrate the magnesium drip. And it's funny, I remember forgetting to wear my sneakers that day. So I was wearing like these high heels and scrubs. And my husband, who's actually a surgeon, saw the picture and was like, "You look like such a medicine doctor." And I remember sort of thinking, I don't know if that's an insult or a compliment, but I'll take it as a compliment. Now, here are the inclusion and exclusion criteria for our study. And I just want to point out a couple of things. Like, firstly, we excluded patients with a baseline GFR below 45. And you may ask, well, those might be the patients at highest risk for AKI, so why exclude them? And the reason for that is, as I mentioned earlier, these patients, for the most part, actually have normal GFRs to begin with a median starting GFR of 87. And we felt like the risks of profound hypermagnesemia in patients with reduced GFR sort of outweighed the benefits of including them. We also excluded patients with bradyarrhythmias like sinus bradycardia and AV block because hypermagnesemia, as you will soon see, can cause bradyarrhythmias. You'll notice we didn't exclude patients with tachyarrhythmias like AFib because magnesium is actually a treatment for those. Now, before embarking on a study like this, I started these studies as a fellow and I was really, really nervous about it. This was something that really hadn't been done before. These are really, really sick patients. And I really kind of wanted to convince myself that this was safe. And so I looked at safety data in a number of other populations. And probably the area where we have the most amount of safety data is our pregnant patients with eclampsia and preeclampsia. And I actually spent a lot of time talking to maternal fetal medicine doctors at our institution and other institutions to figure out sort of what their protocols were. And they pointed me to this one RCT that was conducted in 2008, where pregnant expectant mothers were administered a 6-gram bolus of IV magnesium over 20 to 30 minutes, followed by a 2-gram an hour infusion. And what was fascinating was that a quarter of the patients got 45 grams or more in a short period of time, 24 hours, but there were no significant adverse events. And they were targeting therapeutic levels between 4.3 to 8.4 milligrams per deciliter. Now, again, can we really extrapolate these otherwise relatively healthy women to our very, very sick sort of mesothelioma patients who are older with a lot of comorbidities? Maybe, maybe not. But what else was reassuring was that there's actually some safety data on high doses of magnesium in the setting of acute myocardial infarction and stroke. And there was this one trial conducted now over 20 years ago, the MAGIC trial, conducted by Dr. Elliot Antman, who's actually at the Brigham as well. And so I got to meet with him and speak to him about sort of the study design and also any adverse events. And in this trial, they randomized over 6,000 patients to magnesium sulfate versus placebo. and the patients received about 18 grams of magnesium in 24 hours. And there were, again, no significant adverse events. Now, the study was null. They were trying to see, whether magnesium improved cardiac outcomes in these patients at 28 days, and it didn't. But, I didn't really care about that. I was sort of more focused on the incidence of adverse events. And similarly, there's some data from stroke patients where they received similarly large doses of magnesium, about 18 to 20 grams in a 24-hour period. And again, there were no significant adverse events in those patients. And so that made me feel better. However, David and I still really kind of wanted to be cautious. And before embarking on an RCT, we thought it was really, really important for us to conduct pilot studies first, because something like this really hasn't been done before. We really don't have any idea what is the right dose of magnesium that we should be giving these patients, what's safe, what's feasible. And we also know that, serum magnesium levels really don't correlate with tissue concentrations. There are all these sort of things that you have to take into account. And so we conducted our first magnesium pilot study, and this was starting in the end of 2019, early 2020, just to sort of show you what a labor of love this has been. We've been doing pilot studies for 2 years now. But basically, in this first pilot study, we were a little bit more tentative. And what we did was we gave a magnesium drip that started at zero point 0.5 grams an hour and continued for 36 hours. And we started the drip on the day of admission, which was the day prior to surgery, and continued it until the morning of postoperative day one. And so the patients ended up getting 18 grams total. And we ended up enrolling 5 patients in the study. And as you can see here, we checked serum magnesium levels at serial time points. And so this was sort of the flow chart of inclusion for that first pilot study. And so we had 5 patients that we ultimately enrolled. And these were the magnesium levels that we achieved in these patients. And we had been targeting magnesium levels in the 3 to 4.8 milligram per deciliter range, and that was for the postoperative magnesium levels. And you can see here that we were pretty far from achieving that goal. Probably because these patients did have some degree of magnesium wasting once they got the heated chemotherapy with cisplatin. We really only achieved magnesium levels in the high 2s to low 3s. And when you're doing an eventual trial, you want to make sure that you have adequate separation between a placebo group and a treatment group. And we really didn't think that achieving magnesium levels in the high 2s was going to be all that different from potentially our placebo patients. And so we said, okay, we need to go big or go home, and we need to really sort of put our big boy pants on and actually really try to give a much higher dose. And so we performed a second pilot study where this time we kind of modeled it off of what the OB patients get. We gave them a 6-gram bolus of magnesium over an hour, followed by a continuous infusion that started at 2 grams an hour. And we titrated it to achieve magnesium levels of 4 to 6 milligrams per deciliter, sort of understanding that every patient is going to be very different. And so there should be some sort of dynamic titration of these levels depending on the patient. And this might sound scary, but when you think about kind of when is the threshold where you actually see side effects, we were still sort of targeting a range that was lower than when you traditionally see side effects. But it's funny, there's really not a ton of data on this either. And this was the titration scale that we devised. And, it was a ton of work. I'd stand down in the OR and tell anesthesia time to go up on the drip, time to go down on the drip. We were checking magnesium and serial ionized calcium levels every 3 hours, since hypermagnesemia can cause hypocalcemia. And basically, I didn't sleep the nights that we were doing the study for the 24 hours that the patients were getting the infusion, because it was really, really nerve wracking. We had 2 patients who completed the study without any adverse events. And you can see here, like, now we were really talking about the magnesium levels that we achieved there. We were hitting magnesium levels in the 6s and 7s. And there were no, cardiac side effects. The patients were all intubated the whole time. So they weren't having any of the subjective side effects like flushing, headache that you traditionally might see. But then we enrolled 2 more patients, and they both developed bradycardia, sinus bradycardia to the high 30s, low 40s. And so we ended up having to remove them from the study. And I was pretty bummed about this, and figured, we have to kind of go back to the drawing board and potentially adjust our regimen. And so we conducted a second pilot study. This is now phase 2 of our second pilot study, where we got rid of the 6-gram bolus because it seemed like the bradycardia was happening mostly towards the end of the 6-gram bolus and at the start of the 2-gram an hour infusion. And we also modified our titration scale so that our threshold for holding the magnesium drip was a little bit lower than it had been. And so this is the flow chart of inclusion for these 2 pilot studies that were part of pilot study 2. And you can see that we screened quite a few patients and enrolled ultimately 12 patients who got some magnesium. But for both pilot studies, only 2 patients completed the study. And that's, a reflection not just because of side effects like bradycardia, but you also realize when you're conducting trials in surgical patients, there are a lot of factors that are beyond your control. Like sometimes there are surgical factors. Sometimes the surgeon decides they don't want to give the heated chemotherapy. And so this was definitely a learning experience for me to sort of see the reasons why patients might be withdrawn. And so these were the magnesium levels of the patients who completed this study. So there were 2 patients who completed the study in pilot 2A and 2 in pilot study 2B. And you can see that the magnesium levels were higher in the patients who got the bolus as compared to the patients who just got the drip alone, the 2-gram an hour infusion that was titrated. Now, because it seemed like we were still developing bradycardia in both studies, though, we actually went back and we kind of looked at the patients who did and did not develop bradycardia to try to see, are there some differences? Are there ways that we can sort of figure out how to fix this when we do the RCT? And one thing that stood out to us was that there were 2 patients who had bradycardia who also had a history of CAD, and not just sort of any history of CAD. They had had, recent cardiac events in the last year. And they were theoretically, revascularized and everything. And so we thought it was okay to enroll them. But, this was sort of helpful for us as we kind of plan for the trial, because we realized that these are probably patients that we need to exclude going forward. And so again, this, like I said, this has really been a labor of love, 2.5 years of pilot studies. But we're finally at the point where we are doing the RCT. We just submitted all of our IRB paperwork and we're hoping to get the RCT started in April. And again, this was a little bit like Goldilocks and the Three Bears, where our first pilot study we gave too little magnesium. The second pilot study we gave too much magnesium, and so we realized that probably the right dose to give is a magnesium drip starting at 1 gram an hour, splitting the difference, and titrating to achieve magnesium levels in the 3 to 5 range rather than the 4 to 6 range. And so we're planning on randomizing 80 patients to IV magnesium versus placebo. And we're planning on conducting a modified intention to treat analysis such that as long as the patients get magnesium and HIOC, then they are included in the analysis. And our primary endpoint, at least as of now, is going to be the AUC of serum creatinine measured daily over 7 days in the MAG versus placebo-treated patients, because I don't think we're adequately powered with 80 patients for a binary outcome. And so you can see here, this is kind of the general schematic of the trial. And, we're very, very excited to finally kind of get underway. All right. So I'm going to switch gears a little bit because that was a lot about cisplatin. I'm going to talk about another nephrotoxin that has been around for a long, long time, and that is methotrexate. And I'm going to talk a little bit about this multi-center study that we're doing. Now, methotrexate is a folate antagonist that inhibits dihydrofolate reductase, which is a key enzyme that's sort of needed in nucleic acid synthesis. And so, inhibition of this enzyme results in a deficiency in DNA building blocks that are needed for the nucleic acid synthesis. And methotrexate is particularly active against cells that rapidly multiply. And so that's like cells in the bone marrow and intestine and bladder. And that's why they're particularly sort of subject and vulnerable to toxicity. And methotrexate is predominantly excreted by the kidneys. And what that means is that the kidneys are also particularly susceptible to damage from methotrexate. And this tends to occur in the setting of a lower pH, where the methotrexate sort of crystallizes in the tubular lumen, leading to obstruction and tubular cell damage. And there are probably some other mechanisms as well, like mesangial cell vasoconstriction as well. Now, the treatment of methotrexate associated AKI is usually sort of supportive and revolves around urinary alkalinization and giving leucovorin. At least at our institution, we're really, really aggressive with the alkalinization. We really slam patients with sodium bicarbonate at 150 to 200 cc's an hour for days, sort of trying to maintain a urine pH over 7.5. And then leucovorin is traditionally kind of managed by the oncology teams according to nomograms pictured here. And leucovorin is a derivative of folic acid that basically allows purine and pyrimidine synthesis to proceed in the presence of methotrexate. And the key is that it has to be given within 24 to 48 hours to prevent further methotrexate nephrotoxicity. And using these nomograms, you can sort of follow serial methotrexate concentrations and redose the leucovorin accordingly. Now, the problem, as you can see from this like shaded area here on the graph, is that leucovorin is also not that effective when the methotrexate levels are really, really high. And that is when you need to consider alternative rescue therapies like glucarpidase. Now, what is glucarpidase? It's a recombinant bacterial enzyme that very rapidly and effectively cleaves methotrexate to inactive metabolites in less than 15 minutes. And so 98% of the methotrexate is cleared with a single dose of glucarpidase. Now, what is the current evidence base for glucarpidase? It's actually not a ton. A lot of the research that's been done has been done by Bridget Weidman, who's at the NIH. And, there have been a number of sort of smaller observational studies where they've looked at outcomes of patients treated with glucarpidase when their plasma methotrexate levels were high or the patients had evidence of AKI. And what they were able to show was that glucarpidase was generally well tolerated, and maybe there were lower rates of AKI among patients who received the glucarpidase. And they also showed that glucarpidase is probably not effective if given over 96 hours from the start of the methotrexate infusion. Now, the problem is, though, that glucarpidase acts outside of the cell, and so it cannot reverse the intracellular effects of methotrexate. And that's illustrated here. You can see here glucarpidase is working outside of the cell rather than inside the cell. It's also very expensive and not readily available at some institutions. It costs $27,000 per 1,000 unit vial. And so at some centers, even like major tertiary academic centers, it has to be flown in from somewhere else. There are some studies that are being done by Nelson Lung at Mayo where they're looking at sort of the utility of giving a fixed lower dose of glucarpidase in an effort to sort of save costs in patients with high methotrexate levels and AKI. But the fundamental issue is that there are really no large studies with a control group that have demonstrated that glucarpidase actually improves renal outcomes. And for a drug that's very, very expensive, I think we do need better data to support its use. And so this is the perfect kind of setting to actually do a large multi-center study and conduct a target trial analysis. And that is because there's never going to be a large RCT of glucarpidase treated patients versus non-glucarpidase treated patients for a drug that's given so infrequently. And so in this study, we are going to examine whether glucarpidase treated patients are more likely to have renal recovery compared to matched controls who do not get glucarpidase. And we've sort of leveraged our contacts from other multi-center studies that we've conducted, like our immune checkpoint inhibitor associated AKI consortium. And we have 28 participating centers across the United States. And again, just sort of thinking about target trial emulation and the importance of defining your inclusion and exclusion criteria. We're including patients who got high dose methotrexate between 2012 and 2022. There are patients that must have had a traditional sort of length of infusion of their methotrexate. They have to have evidence of AKI, and they have to have been treated with glucarpidase within 96 hours from the start of the methotrexate infusion. And we're excluding patients who did not get glucarpidase within 96 hours. And we're planning on matching patients by site, AKI stage, and plasma methotrexate levels. And our primary outcome is going to be survival to hospital discharge with renal recovery. And what is that going to look like? Well, we want these patients to be discharged alive, not dependent on renal replacement therapy, and have a decline of at least one stage in their AKI severity at discharge compared to their peak AKI stage in the 96 hours following the initiation of methotrexate infusion. And, David and I have become quite neurotic as we're building these red cap databases that, we really want these databases to be really, really perfect, particularly when you're conducting these multi-center studies and you have everybody from medical students to RAs to doctors, really kind of inputting data. So we've made these really, really fancy red cap databases that we're using to collect granular data, like data on the amount of fluid and leucovorin, urine pH, blood pH, serial labs. And we have all of these built-in data validation tools to make sure that, if there are keystroke errors, that we're able to capture that. And we do have some preliminary data thus far. We don't have data on our controls yet, so you have to take this with a grain of salt. But we did end up collecting data on 243 patients treated with glucarpidase. And ultimately, after implementing our inclusion exclusion criteria, we ended up with 197 patients. And that's actually pretty remarkable considering this is a drug that, like, even at our institution is given once every 2 years. And you can see here that most of the patients did receive glucarpidase appropriately early in the first sort of 3 to 4 days following the initiation of the methotrexate infusion. Perhaps not surprisingly, these patients all had pretty severe AKI. 2/3 of the patients had stage 3 AKI, and about half of those patients needed dialysis at the time that they were given glucarpidase. And it makes sense because if you're going to give, a very, very expensive drug, you probably want them to have fairly severe AKI. And then these are some of the sort of baseline characteristics of the patients. And, a couple of things I want to point out is that the patients had a relatively quote unquote normal baseline serum creatinine. Again, these are cancer patients who have low muscle mass. And so take that with a grain of salt. But what was interesting is that we did find that 70% of these patients did have a decrease in their AKI stage by discharge. Now, again, we cannot sort of say this is better than not doing anything at all because it's possible that our controls may have similar rates of recovery. But I think this is sort of compelling data nonetheless. Now, another sort of application of TTE and target trial emulation can be done in immune checkpoint inhibitor associated AKI, which is another area that I've done a lot of work on. And we sort of leveraged our multi-center study of patients treated with steroids for their immune checkpoint inhibitor associated AKI and looked at whether longer versus shorter durations of corticosteroid treatments for ICPI associated nephritis was associated with sort of a difference in outcomes. And our primary outcome in this study was recurrent immune checkpoint inhibitor associated AKI or death in the 30 days following the steroid taper. And we found no difference between a quote unquote shorter duration versus a longer duration of corticosteroids. Now, again, what we really need is an RCT, which I do hope to conduct one day. But I do, until we do have that data from trials, I am sort of allowing this to guide my practice where I'm tapering steroids a little bit more quickly than I used to. So just to highlight, I think in onconephrology in particular, where, there's a lot of sort of rare events, there's not a lot of data out there. I think we really need to kind of leverage our contacts at other institutions and do some of these multi-center studies and collaborate with one another. And, so these are a couple of the multi-center collaborations that I'm, running at the moment. So I talked to you about the cisplatin-associated AKI consortium, the ICPI AKI associated consortium, the glucarpidase study. I'm also doing a study looking at outcomes of plasmapheresis for light chain cast nephropathy, since all the trials that were done with this were in the early 2000s or before, and that was before the advent of clone directed therapy. So I'm partnering with Nelson Lung to do that study. And then we also need translational research as well. And so we have some partnerships with some other centers to look at biomarkers of immune checkpoint inhibitor associated AKI. So I'm just going to close with a few words about the creation of the American Society of OncoNephrology. Hopefully, I've piqued your interest in onconephrology in general. I think there's a lot that we have to learn. There are a lot of gaps in our research knowledge. And so, because of that, in 2021, I decided that we really needed a formal organization to kind of promote more research in this area and also clinical activities and education related to onconephrology. And so, I first kind of thought of this in August of 2021, and I went to Canard and I said, look, everybody knows you, nobody knows me. So can you help me get this off the ground? And together we sort of picked some founding members who we felt like were leaders in this field. And we had our first meeting in October of 2021. I submitted all the paperwork to sort of make us official in November of 2021. We had, friends, cousins, brothers, somebody or the other develop a logo for us in November of 2021. We had a Stanford student develop a website for us. We submitted an editorial on the creation of ASON to the Journal of OncoNephrology and actually negotiated a subscription with them in January of 2022. And we announced our creation and welcome new members about a year ago. And in a relatively short period of time, we already have 134 members across 14 countries, and we're growing every day. We have a lot of different sort of subcommittees focused on education, research, developing position statements like GFR measurement in patients with cancer and immune checkpoint inhibitor associated AKI management. We have a website committee, event CME committee, social media committee. We have monthly educational symposia. We just had one last week. We're partnering with industry and ASCO since we know that you really need to bring oncologists into the fold in order to sort of make something like this more legitimate. And then, we also host the annual OncoNephrology Symposium, which I hosted at Brigham and Dana-Farber in the fall of 2022, which was a big success. So anyway, with that, you probably learned that, all career paths, as probably many of you know, can take kind of a long and windy road. And despite all of those, initial kind of failures at the beginning, I sort of like to think that they kind of helped pave sort of the road to where I got today. And I'm really happy with kind of what I'm doing, but I know it's not always easy. And so with that, I want to thank David Leaf, who's sort of been my sensei throughout all of this, all of our collaborators at all of our sites around the world, the leaders of ASON, particularly KNAR, my husband, Eric, my 2.5-year-old Nayla, and our next baby who's on the way. So thank you very much. Happy to take any questions.
Thanks, Shruti. That was a wonderful overview. And you actually, gone what your mentor said you should be doing and accomplished that in a short period of time. So if people have questions, please raise your hand and then you can unmute yourself and ask. But I'll start the ball rolling. This your career description is the most fascinating aspect, right? The onconephrology work is great, but I have a particular interest in that. So how did you become the onconephrology expert, right? These days there are a few programs that offer fellowships, but I think you taught yourself on your own. Is there something else you can say for listeners in the audience who may want to do something?
Yeah. I talked about how I did some reading and stuff, which is all kind of well and good, but I think some of the other things I did that were super helpful was that I actually spent a lot of time, when I first took on the role in 2019 and before the pandemic in 2020, I actually spent time rotating through the different oncology service and observing rounds and shadowing different oncologists in clinic. Not just to sort of learn about the different drugs, because I think you can probably do that, over time with reading, but also just to get face time and exposure, kind of learn how they think, what are the problems that they sort of perceive are the biggest problems. And I think they also just appreciated that there was a nephrologist who, was interested and wanted to observe their rounds. And so I sort of made it a point to do that at least once a week at the beginning. And that's how I got to know people. That's how I forged also some of my initial research collaborations. And so I think that's a really important piece is that, you really need to kind of try to have FaceTime with the oncologists and learn from them, what they perceive to be the biggest clinical and research questions out there.
Yeah. So the again, pushing a little bit more about that is there are these fellowships that are coming up.
Yeah.
I don't know if you know anything about them, or you could comment on that.
Yes.
And
Yep.
can people come and work with you, for example?
Yeah.
Are you guys thinking about having a fellowship like that? Like you have a third
Yeah.
year, right? Which most of the programs don't have, which
Yeah.
allows you to get extra learning. But for others, what
Yeah.
options do we have?
Yeah, no, it's a really good question. It's an important question. So I actually sort of tried to explore having an onconephrology fellowship sort of more formally at our institution, and there are challenges. There one is funding. How do you actually fund that fellow going forward? And other institutions have a lot of support from the cancer center where they'll actually sort of help support that fellow financially, or people like Kanar got they got big sort of philanthropic grants to financially fund that person. We have another added challenge at our institution, which is that we're a joint program between the Brigham and Mass General. And so, for instance, if we wanted an ACGME accredited fellowship, like it'd have to be joint between Mass General and Brigham slash Dana Farber, and sort of what that looks like and who kind of takes ownership of the fellow is kind of complicated. So it's not kind of out of the picture. I mean, we don't have a formal onconephrology fellowship. There are probably, I think, 6 programs around the country and Canada that do. And I'm hoping that we get there. But I think there are a lot of logistical and financial challenges that come with that. I mean, right now, because we're still sort of heavily focused on research, if there's somebody who wants to do onconephrology research, they'll work with me on the Dana Farber side, or Meg Seiss on the Mass General side. And Meg and I collaborate on stuff together all the time as well. But I think there are also other steps that we're kind of taking to get there. So one is that we're now developing an onconephrology consult service. And we just hired 2 or 3 more onconephrologists just because our volume is getting so high of patients that we're seeing both on the outpatient and inpatient side. And so we're actually going to have a separate onconephrology service. And I do think that that's potentially one step forward to us being able to grow an onconephrology fellowship, because right now that service is not going to be manned by a fellow. But hopefully, if we generate sort of additional revenue from the service, and we can use that to fund a fellow who could then rotate specifically on that service.
Yeah, that would be helpful. And the I guess the other way is, people could join the American Society of OncoNephrology or attend all these educational symposia. But I think
Yeah.
there are some qualifications, if I'm not wrong, to be a member. Can anyone join up because we've got an interest in
Y-
ASO in onconephrology
y-
field?
Yeah, we actually had some requirements, but they're pretty kind of basic. Like you have to have like submitted an abstract in the last 3 years where you were like an author, and I think we've even stopped kind of looking at people's qualifications. We just sort of will take anybody who's interested, because at the end of the day, if you're interested enough to join and pay the fee, then who are we to say that you can't join? So um yeah, I mean, we sort of theoretically have these kind of qualifications, but in the end, anybody can really join.
That's awesome. I hope some of the people in the audience today are going to take this up.
I would
Uh,
love that. Yeah.
I'm definitely going to tap on some shoulders after the meeting. The With respect to, where do you think onconephrology is going? And maybe this is too early,
Mm.
but in the interventions you mentioned, glucarpidase is something I learned about half an hour ago. Uh, and magnesium has been around forever, right? So it's
Yeah.
like a
Yeah.
really, really old agent and a really, really new agent.
Yeah. Yeah.
What are your thoughts about the future of interventions, or what's going to happen in onconephrology?
Yeah, I mean, what's sort of neat about oncology, I think, unlike nephrology sometimes to some extent, is that it's constantly evolving. Like day to day, new therapies are coming out in oncology. And that means there's always going to be more problems for us to explore. And, I talked a lot about, some of the epidemiologic research that we've done, which is, again, all well and good. But I think that we really need to now take a step forward to understanding the mechanism of injury of some of these agents, like even immune checkpoint inhibitors. We know what the most common lesion is, which is interstitial nephritis, but why is it that some people get it and others don't? There's also really no clinical features that separate out a patient who has AKI from other causes versus AKI from the immune checkpoint inhibitor. So we have to biopsy them, and that's a challenge. And so we need non-invasive biomarkers in those patients. And so that's an area I think that we're all sort of segueing into, which is sort of doing more translational research in biobanking and trying to sort of figure out, are there potentially non-invasive biomarkers for some of these patients? And then, yeah, I think, obviously this is a field where there's no RCTs. I mean, I feel like my magnesium RCT is going to be like the only RCT, in existence in onconephrology. And so clearly we need kind of more work in that area. But as I highlighted, it's not always practical to conduct RCTs in these patients. And there are a lot of challenges that kind of come with that as well. But, you know, for immune checkpoint inhibitors, for instance, we are planning on submitting an NIH grant to actually conduct an interventional study in patients with immune checkpoint inhibitor associated AKI to see if certain treatments work better than others. There's a number of other treatments, infliximab, tocilizumab, that are out there. And so I think that's really the direction that we sort of as a subspecialty need to go into, which is translational research and more interventional studies.
Yeah, and it actually, there is room to grow. Like you said, I hadn't thought about it, but in basic science, not just clinical
Yeah,
trials and
exactly.
epidemiology, there are many, many careers to be made in this field.
Yeah.
If I talk to my fellows, they're all like, "Oh, what do you want to do?" It's like transplant or
Right.
GN. It's like, come on, everyone does that.
Yeah.
The way you stand out is by doing something that no one has or is doing, and onconephrology is completely
Yes,
ripe.
it's wide open. Yes,
Yeah,
it's wide
yeah,
open, and that was sort of the reason why I formed the society, and hope that fellows kind of become more and more interested in the field.
fantastic. Kevin.
Yeah, thank you, Dr. Gupta. I really enjoyed the talk, and I really think it's exciting that you're developing this this program, unique program. But my question has nothing to do with that. I was interested in whether you could comment on susceptibility to AKI, either due to cisplatin or methotrexate, males versus females. And the reason I bring that up is because recent studies, single cell RNA studies, show marked differences in proximal tubule metabolic pathways in the human sample. So have you been able to dissect that out yet, or in your own studies, or what can you comment on?
It's a great question, and yes, you're absolutely right. There is supposed to be potentially like more of a female predisposition to developing kidney injury, like from cisplatin. And so, I mean, again, I'm not a basic scientist, so I can't necessarily dissect that out myself. But that being said, when we have a data set of 45,000 patients who got cisplatin, what better way to kind of look at that, and except in something like this, we'll have data on obviously a lot of patients where we can look at whether sex is associated with kidney injury in these patients. I mean, at least preliminarily, when I've looked at the data, there does not seem to be an association. But again, I do think you're right that we know from these basic science studies that there is a predisposition, and so that's something that's sort of worth exploring further.
Fantastic. So
that's great. Thank you.
Thanks, Shruti. So we are finishing right on time. So thanks, Dr. Gupta, again for giving this marvelous overview, and really good luck and congratulations on
Thank
everything
you.
you've done so far. We will probably take up your offer in a couple of years to see where the research is going.
Sounds good.
Yeah, for those in the audience, you will be getting a evaluation form, so please fill that one out. And for those who may have missed, this will be available on our channel as well. Thank you again.
Thank you so much for having me. Have a good day, everybody.
Bye-bye.
Bye-bye.